Did you know that 1 out of 25 kids will have a seizure caused by fever? Is the most common neurologic disorder of infant and young children. In the next video, I'll tell you all what you really need to know about febrile seizures. So, first, what is a febrile seizure? If you have a patient with fever and seizures, you have to consider if your patient meets these criteria in order to call it febrile seizure. First, a convulsion associated with a temperature greater than 38 Celsius or what is equal to 100.4 Fahrenheit. A child older than 6 months but younger than 5 years of age. Absence of a neuroinfection. Also, absence of acute systemic metabolic abnormality that may produce convulsions. Let's say hyponatremia. If you have a patient with a sodium in 120 and is seizing, of course you shouldn't say, oh, most likely it's the fever. Let's give him Tylenol. And last one, no history of previous afebrile seizure. This is also important and very easy to forget. Always ask if the patient has seized without a fever, because if he had, then it's not a simple seizure. Now, let's talk about the clinical presentation. We can have two different presentations, simple and complex. I'm gonna tell you about the simple first. Needs to be a generalized seizure with a short duration and not recurring in a 24-hour period. Now, the complex is of course the opposite. Focal, long duration, recurring in a 24-hour period. Before we continue, I want to tell you a very important thing. It can happen that the patient has a non-convulsive seizure, meaning that the patient is seizing but is not shaking. A patient with closed eyes and a deep breath most likely is in a post-ictal state. A child with persistently open and deviated eyes may still be seizing, even if convulsive motor activity has stopped. Now, another important fact. When do complex seizures most commonly present? In younger patients and in those with abnormal development. Okay, let's review something quick. Why do the seizures occur with fever? The theory is that it's due to a developing nervous system to the effects of fever, but also the combination with an underlying genetic susceptibility. There was a study where they classified patients in two groups. The first group, infants with high fever, and in the other, infants with low-grade fever. The incidence of seizures was higher in the patient with higher fever, regardless the rate of rise of the temperature. This is important because before, it was a common thought that a high rate of rise was a risk factor for seizures. In conclusion, high fever is a risk factor. But why not every child seizes? Because there are variables that modulate the seizure threshold. Translation: every patient is unique. Some can seize with a fever of 101, others with 102, and even others won't seize with a fever of 104. Now, there are other risk factors. Viral infections are commonly identified in association with febrile seizures. In contrast, bacterial infections are infrequent. Herpes virus 6, also known as roseola, and influenza are highly associated with seizures. Are you thinking why? They are associated with high fever. Okay, now, the most important part, what to do. It all depends. Let's say that you are in the ED and the nurse brings you a patient from DRASH. A 2-year-old girl that moms tell you that the whole body was shaking for 1 minute and after that was drowsy for other 5 minutes. At arrival, vital signs are stable, but with a temperature of 102. The patient has a reassuring non-focal exam, no meningeal signs either. She hasn't had seizures before and has no past medical history. This morning, when she woke up, mom noticed cough and runny nose. What do you do next? This is a typical story of simple febrile seizure. In this case, diagnostic testing is not necessary. But what do you do in the case that a child presents with a complex seizure? Particularly if this is the first, he requires a more individualized approach, since the likelihood of an alternative etiology, such as meningitis or an underlying structural or metabolic cause, is higher than in the patient with just a simple seizure. And also, there is a slightly higher risk of future afebrile seizures. Every time you have a patient with febrile seizures, you need to focus on a careful history to identify any underlying medical or neurological condition that increases the risk of a serious infection or any underlying structural abnormality. Also, you need to assess the immunization status, personal or family history of seizure, and history of neurologic problems or developmental delay, which in this case wouldn't be classified as a simple seizure. On exam, pay attention to vital signs, meningeal signs, a tense or bulging fontanelle, and focal differences in muscle tone, strength, or spontaneous movement. Any of these signs should prompt consideration of an alternative etiology, such as meningitis or an underlying structural abnormality. Also, very important is level of consciousness. Post-ictal drowsiness usually resolves within 5 to 10 minutes. Encephalopathy beyond this time period should prompt increased suspicion for possible neurologic infection or a severe systemic infection or maybe an ongoing seizure activity. Important. Be careful with children younger than 12 months of age. They also warrant special consideration. Signs and symptoms of meningitis may be more subtle in this age group. Now, workup. As I said already, diagnostic testing in simple seizures is most of the times unnecessary. Another short, generalized seizure repeated twice in 24 hours is by definition complex, but wouldn't necessitate an EEG unless the neurologic exam were abnormal. But keep this in mind. There are some situations where you should do something more than that. If the patient has a complex seizure, an EEG or an MRI with a neurologic follow-up sounds like a good idea. The American Academy of Pediatrics also recommends a lumbar puncture in these situations. If there are meningeal signs or clinical suspicion of meningitis or intracranial infection in infants between 6 and 12 months of age, if the immunization status for Haemophilus influenzae or strep pneumoniae is deficient or unknown, and last one, if the patient is on antibiotic, because antibiotic treatment can mask the signs and symptoms of meningitis. Now, another common situation. If there is a history of possible dehydration like vomiting, diarrhea, the patient has no oral intake, or there are physical findings of dehydration or edema, you should consider electrolytes, blood sugar, calcium, BUN. Maybe the seizure is secondary to metabolic causes. Okay, now, who are you gonna treat? As with any seizure, febrile seizures that continue for more than 5 minutes should be treated. Benzodiazepines are effective in many cases, and of course, don't forget to treat the underlying cause of the fever later on. Which patients will more likely recur? Those with young HR onset, those with family history of febrile seizures in a first-degree relative, and in those who present with seizures in the setting of low fever. Also, when the seizure started briefly after the onset of fever. And finally, don't forget to educate parents about the risk of recurrent febrile seizures and about the low risk of future epilepsy in these patients, even in those with complex seizures. Well, this is what you need to know about febrile seizures. I really hope it was helpful. Thank you for watching.